Greetings. This lab will focus on the appendicular skeleton and articulations. This will include the Psoriasis exercises 8 and 9. There will be one handout for each. So you'll have one for exercise 8, one for exercise 9. But we'll get more into this in a bit. Let's get started. Of course, you are to review the exercises 8.1 to 8.6. Now, if you do not have access to skeleton disarticulated bones and lab manual diagrams, no problem. What you can do is go over the review sheets to get into the exercise, as well as review the videos, the lab videos, which will cover information about the appendicular bones, as well as the joints. There is a good X-ray imagery taken of how joints will move, etc. And I'll see if I can have that duplicated and put into the lab as well as it's already in the lecture section. You want to keep in mind again, just like the axial skeleton, that when you review the bones, make sure that you can identify the bone markings on each of the bones and comprehend the function of these markings. As always, you are to complete the handouts and basically submit them, upload them by 5 p.m. on Friday. Now, when you talk about the appendicular skeleton, this basically consists of upper limb segments, which include the pectoral girdle, that's the scapula and clavicle, the humerus, ulna, radius, carpal bones, which there are 8 of them, the metacarpals, which there are 5 of them, and the phalanges, which there are 14. It also consists of the lower limb segments, which is the pelvic girdle consisting of the coxal bones, which are the ilium, ischium, and pubis. It will also include the femur, tibia, fibula, tarsal bones, of which there are 7, and metatarsals, which there are 5, and phalanges, which there are 14. Now, the clavicles and the scapula connect the upper limbs to the axial skeleton. There is something to keep in mind, except for the clavicle, which attaches to the sternum. There is no clear bone-to-bone connection. Okay? Now, that sounds kind of like, well, what do you mean by that? We'll see in a minute. You want to keep this in mind, though. One, the clavicle is one of the most common bones, particularly for young kids, to break. Okay? And that's because there's a lot of forces put on it. The pectoral girdle forms a bony strut that suspends the upper limbs lateral to the trunk. As I said, it's an incomplete ring formed with the scapula and the clavicles, which attaches to the manubrium, which is part of the sternum. The clavicles articulate. In other words, when I use the term articulate, form a joint with the sternum at the sternoclavicular joint. This is where the sternum end meets with the clavicular notch of the sternum. There are only 2 joints between the pectoral girdles and the axial skeleton. The acromonial end of the clavicle articulates with the acromonum, which forms the acromonial clavicular joint. The ligaments stabilize the conoid tubercle and the costal tuberosity. So let's take a look at the clavicle first. Here's the medial part. And if you get a hinting right off the bat, if they tell you this is the sternal end, this is the end that's going to be attaching to the sternum. This is the costal tuberosity. Notice there's this indentation right here. Now this is the inferior view I'm pointing out for the conoid tubercle. If you look at the superior view, you don't see any of these bone markings as clearly until you get to the acromonial end. Okay? Now, as you can see, the 2 joints, the sternoclavicular joint and the acromonio clavicular joint. This is where the acromion of the scapula attaches to the clavicle. You'll notice also that the clavicle comes in contact with the clavicular notch of the sternum. You'll also know that the scapula forms a shallow ball and socket arrangement with the humerus. Now, the scapula, you're going to have to take note of a variety of angles and shapes and fossas and cavities. When we look at the anterior view, this consists of the acromion, which is continuous with the scapular spine. The coracoid process consists of the superior, it's supposed to be medial, not medical, medial and lateral border. The lateral border you can kind of locate in part because it's going to be the area where the axilla, the armpit, is. And so the muscles that position the scapula attach to each border. I want you to walk away with this main thought. What stabilizes the scapula? Mostly muscles and also ligaments. It is not attached to the back part of the ribs. Okay? It's not bone to bone. You may see that in skeletons and they have to just put a bolt through it, etc. Not attached. The corners of the triangular shape, you have the superior, inferior, and lateral angle. The subscapular fossa is the depression of the anterior surface. You have the glenoid cavity, which is kind of cup-shaped. Now, this is where the scapula articulates with the humerus, and this forms the glenohumeral joint. Note, this is a shallow cup, and we'll compare that to, let's say, the hip joint later. Here's the glenoid cavity. Here's the acromion. Here is the coracoid process here. Now, this is a lateral view of the right scapula. Let's take a look here. And what you have here is the anterior view of the right scapula. You have the inferior angle, the lateral angle, the superior angle. And the superior angle corresponds also with the superior border. Lateral angle, lateral border. Medial, the inferior angle, and the medial border. Here's the coracoid process and the acromion. Let's go to the posterior side. And that is if you're looking from the back. And you can see here this scapular spine, the acromion, the supraspinous fossa, okay? The infraspinous fossa, okay? Now, if we start going down into the upper limb, the arm bones are extremely critical. There is a complete table on pages 114, 115. So you have the humerus, the radius, the ulna. In Syracuse, as I've mentioned before, that when you have some of those pages that, of course, you're not going to be handing in to me, you should be filling out all of that information because it is going to be absolutely essential to help you when you are preparing for the lab practical exams. In these three bones, you want to locate all the listed bone markings for these bones. Notice the interaction of the bones at the elbow joint as well as the proximal and distal radial ulnar joints. Here's what I mean. Let's take a look here at the humerus first. Here is the head. Here's the lesser tubercle right here. The anatomical neck, the greater tubercle, the intertubercle sulcus. This is kind of an impression right here. Now, this is the surgical neck as opposed to the anatomical neck. And if you go down the shaft, you will see this tuberosity here. That's called the deltoid tuberosity. Now, mind you, this is all, of course, the anterior view. At the end, you have the radial fossa, the lateral epicondyle, you have the capitulum, and you have two areas here of the trochlear. This is where you're going to form that elbow joint. You have the coronoid fossa and the medial epicondyle. Now, if you look at this from the posterior view, you're going to see a couple of just slight differences. Again, the trochlea right here. The oleocranial fossa, which of course you're going to have that hook extension of the oleocranon that's going to fit into it. Radial grooves, again, surgical neck, anatomical neck, greater tubercle. You can't really see clearly the lesser tubercle. Keep in mind, these are attachment points for tendons, ligaments, muscle. If you go now to the ulna and the radius, let's look from a posterior view point. Remember I said that oleocranion, that's going to form, and it's going to fit into, when you make the arm straight, you have the trochlear notch, which is going to go basically into that oleocranion pocket that I was mentioning earlier. Now, the interesting thing with these two bones is they actually have a notch down here and up here. That's because you have the proximal radial ulnar joint up here. What stabilizes all of this, and I'll get into it in a second, you have the distal radial ulnar joint here. What helps stabilize the two bones so they don't really separate is the interosseous membrane, which is right here. This is the ulna, this is the radius. The radius is much larger, okay? It has a head, a flattened area right here. Of course, you got the neck. Then you have that radial tuberosity right here. And then you get down to the radial styloid process right here. And it's also here. This is if you were having a posterior view. This is an anterior view. Notice that you're going to have this coronoid process right here. So it's going to fit in like a joint, which is what it is. And it's almost like a ball and glove. You have the radial notch here, okay? You have the ulna that moves downward, and then you have the head of the ulnas down here. So the interesting thing is you have an inverted positions. The head of the ulna is near where the carpal bones, the wrist, are going to be. The head of the radius is going to be up where the elbow is, okay? Now, bones of the wrist and the hand. Review the proximal carpal and distal carpal bones and their articulations to the radius and to the ulnar and to the metacarpal bones. You need to review that the medical numerical labeling of the metacarpals. That's absolutely essential. You're going to also locate the pollex. You want to review the phalanges and the interphalangeal joints. So what am I talking about here? Okay, first off, here we have the radius, here we have the ulna. All right? So, what do you have for the proximal carpal bones? When we talk about proximal, these are the bones that are closest to these two major bones here, the radius and the ulna. You have the pisiform here. Underneath it, in sort of a, which acts sort of like a pocket or a stabilizes, is the triquium. You have the lunate here. And then you have the scaphoid here. Now, remember, all that blue is basically hyaloid cartilage because you have so many joints in here. The distal carpal bones are the trapezium, the trapezoid, the capitate, and the hamate. If you start with your thumb, and you count the metacarpal bones, this is where you're going to get the Roman numerals. 1, 2, 3, 4, 5. The metacarpals are located in what you would consider the fleshy part of your hand or your palm. Then we get to the joints here. And we have proximal, middle, distal. Now, you notice I said, well, wait a minute now. The phalanges are only 14. Yeah, that's true. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Oops, guess what? 1, 2. This is referred to as the proximal, and this is the distal when it comes to the thumb. That's all you have, okay? We're going to start down in the lower segment. This is the pelvic girdle. which consists of coaxial bones, ilium, ischium, and pubis. As I've mentioned before, also as you go into the legs, you're going to see the femur, tibia, fibula, tarsal bones, which there are 7, metatarsals, there are 5, and phalanges, there are 14. Now, really, the function of these lower limb segments is to bear the body weight. Therefore, you're going to see them having a greater amount of compact bone, okay? And in some cases, they're going to be very thick with it because they are going to be handling a lot of weight from the body. You want to review the table on page 118. Complete tables on 119, including the female-male comparison. This is absolutely essential. I want you to be able to understand the differences and how that plays a role in walking and how the hips are set in such a way comparing male and female. As a matter of fact, from a forensic approach, obtaining the pelvic girdle, let's say you only have part of the bones present, but obtaining the pelvic girdle is usually one of the most reliable means to identify whether the unknown was male or female. Also, you want to review all bone markings in the bony pelvis and identify and compare what is considered true and false pelvis, and identify the sacroiliac joints. Here we have the hip bones. So, in the dark purple, okay, you've got the ilium. In the yellow, you have the ischium. In this part that's kind of light red, this is the pubis. You will note how these 3 bones contribute to the acetabulum, the site where the femur meets in to form a ball and socket joint right here. Okay? Let us go through this. If you look at a superior view of the pelvis, you will have the area from pelvic brim to pelvic brim considered the false pelvis. The true pelvis is the area in here, the pelvic inlet. Now, this lower part is the pelvic outlet, all right? And of course, you have the pubic syphus right here, which is just basically cartilaginous tissue. If you look from an inferior view, so looking bottom up, you'll see the pelvic outlet here. You'll also note there are ischial spines here. These are not a bad thing because really what they are attachment points for various muscles, etc. When you look at a comparison of male to female, you will note differences in the cranial structure, size, weight, teeth, etc. But it is the pelvis that really gives you between the pubic angle here and the obturator foramen, the acetabulum, the coccyx, the pelvic outlet, the pelvic inlet, the iliac fossa, the sacrum, the ilium, and the general appearance. You can tell this is male and this is female, okay? There are some slight differences in bone mass and density and bone markings. Bones of the femur, patella, tibia, and fibula. You are to identify the bone markings on all bones. You are to identify how the femur and the tibia form the knee joint. Notice I didn't say the fibula. The fibula doesn't play any role in the knee joint. You are to review and identify the proximal and distal tibiofibular joints, and you are also to complete the tables on pages 120 and 121. This again is not necessarily the structure for your hand in, but it is going to help you to really comprehend the bones, the bone markings, etc., of these lower limb bones. So if we start off with the femur, we have the fovea captus as part of the femoral head. There's a bit of tissue that comes out of this, attaches right inside the acetabulum. Now, you see this angle here? This is basically where the forces are aligned and come down and radiate out on this side. From the medial supracondyle ridge, you can see this development. In other words, how you're holding your weight up. You have two trochanters. You have a lesser trochanter here, a greater here. When you look at the entire arrangement of the joint, it's wrapped with a variety of ligaments and tendons and, to a less degree, muscles that basically provide the stability of holding up the weight and being attached then into the axial skeleton. This is the area of the shaft, and then we get down to the knee joint. If we look at it from an anterior view, you're going to see the adductor tubercle, the medial epicondyle, the medial condyle, the lateral condyle, and the lateral epicondyle. This is the patellar surface. That is where you are going to have the kneecap, the patella, attached, okay, or going and being located next to. Now, this is if we look anteriorly. If we look posteriorly, look in the opposite direction, okay? What you're going to see, of course, is the intertrochanteric crest right here. The gluteal tuberosity, yes, the gluteal muscles attach. The linea aspera, the lateral supracondylar ridge. Here's the medial one down here. You have the popliteal surface right here. The intercondylar fossa here with the lateral epicondyle and the lateral condyle here, the medial condyle, the medial epicondyle, and of course the adductor tubercle. Now, here's the point when we deal with the patella, which is basically what you would call the kneecap. We have base, apex. Right here is the attachment area for the patellar ligament, which attaches patella to the tibia. Right up here is the attachment area for the quadriceps tendon, which makes up the thigh muscle. If you were to turn this around and look at it from the posterior view, you're going to find it's much, much smoother, because that's the area that's going to be coming up against this knee joint area. So the lateral fossa here and here for the lateral condyle of the femur. Here and here is the medial fossa for the medial condyle of the femur. And this is the articular surface of the patella. What you can't have is this being rough, because it would begin to erode away the cartilage tissue that helps this joint be so functional. Now we get down to the tibia and the fibula. Okay, first off, real simple. Tibia is the bigger bone, fibula is the smaller one. Because they're next to each other, again, to stabilize them, you're going to have this interosseous membrane right here, right here. I'm going to work with, of course, first what would be basically this would be the anterior view. So what you have here is the head of the fibula here. Comes in contact with the tibiofibula joint right here. And of course, you've got the lateral tibial condyle here. Note that the head down here for the tibia, this is the head of the fibula. Okay. Now on this medial side here, you have the medial tibial condyle. Now, remember something. If you're getting lost with the terms, think of it. Medial toward the midline. So this would be on the inseam of your leg. This would be on the outer side. This is the tibial tuberosity, the anterior margin. the tibia, obviously, the medial malleosus. So you kind of think of it as almost that little bump that you have above your ankle. And of course, you have the inferior articular surface here and the lateral malleosus here. Okay, that's on the outside of your leg. You can kind of feel that bump. Now, if you look at the superior side, you have the intercondylar eminence. This is sort of like a little peak and fits in with the articular surface of the medial tibial condyle. And the articular surface of the lateral tibial condyle is right here. You've got the lateral tibial condyle right there, and the head of the fibula is right here. Okay, so head of the radius is down here. You've got basically two joints. You've got the superior tibial fibular joint right here, the inferior tibial fibular joint right there. Okay, and again, interosseous membrane between tibia and fibula. Then we have the lateral malleolus of the fibula. Now we've moved into the bones of the ankle and the foot. You want to review the tarsal bones, which there are 7, and review how weight forces are carried from the talus to the calcaneus. Remember, the calcaneus is the heel. And other tarsal bones, the navicular cuboid and the 3 cuneiforms. You want to review the Roman numeral labeling of the metatarsus. Locate the hallux. It's the big toe. Okay, pollex is thumb, hallux is big toe. And then you want to review the phalanges, and there are 14 of them, and the arches of the foot. So here we go on sort of the superior view. You see all of the weight coming down on this talus. Okay, this is the trochlea of the talus here. This is where we have the ankle, because the back part here is your heel, calcaneus. You've got the talus, you've got the navicular, the cuboidal, and 1, 2, 3 cuneiform bones. When we look at the metatarsals, again, like the hand, the metatarsals start with 1, 2, 3, 4, 5, and you start at the side where the big toe is, where the hallux is. And again, as you're going through all of this, you have the articulations between the tarsals and metatarsal bones. You can see here the joints. The phalanges, of course, you're always going to have as proximal, medial, distal, okay? And what you have here with the big toe is obviously just proximal and distal phalanx, okay? Phalanx is sort of the singular, phalanges is the plural. Now, if you look at this from a side view, a lateral view, here you're going to have a greater appreciation for this, because here's all your weight sitting down on this one bone of the talus, dispersed then down through the foot and through the calcaneus, okay? That's the heel bone. Right at this point here is where the calcaneal tendon, otherwise known as the Achilles tendon, is attached to. So you got the lateral surface here of the trochlear. You got the cuboidal bone, navicular bone, and then the cuneiform bones. And then we go 1 through 5. And you can see how this is sort of on the lateral view. You can kind of hint that there's some sort of an arching here. Now, there are several main arches. There's a transverse one that goes across. And then there is the main longitudinal arches. And you can see how they kind of rise up and then come down. You can see where they come down from the metatarsals and eventually to the rest of the phalanges. Okay? Now, when we talk about joints, these are articulations, sites where 2 or more bones meet. But notice in the big red letters, movement is not necessary. Joints are where bones meet but they don't lead to necessarily to movement. Joints are the weakest parts of the skeleton. They resist crushing and tearing forces that can force them out of alignment. Here is another concept map that I made for you that divides all of the joint classes. If you note here, you have the fibrous joints. So between the two bones is fiber of one type or another. So you have the sutures of the skull, the syndesmosis, some are immobile, the gomphosis, which is really the joint where the tooth in the jaw meets, okay, in the maxilla and the mandible. The cartilaginous joints, you have two types. Those that are immovable, the synchondroses, such as hyaline cartilage, is present. You have a few, the symphyses, which are amphiarthrosis, meaning that there's a slight movability in the joint. They have fibrocartilage present. And then we have the synovial joints, where you are freely movable. And all of these types, plane, hinge, pivot, condyloid, saddle, and ball and socket, all are important. They all are movable in one way or another. Here is another nice table that I encourage you to review, to get used to the terms, to see where they are. Basically the different types and the different mobility. So let's explore this a little bit more with fibrous joints. There are three types. First, very common in the skull bones, sutures, where bone and bone meet, okay? But you don't want any movement there because the skull is essential for the protection of the brain. The syndesmoses, this is an interosseous membrane between the ulna and radius, or the fibula and tibia, or the distal tibiofibular joint, or the coracoclavicular joint. Gomphosis, this is your peg and socket, the tooth in either the maxilla or the mandible, and it's held by periodontal ligaments. Okay, so you can see all of these as you go through these diagrams, and I encourage you to go through them. Here, of course, are sutures, the lambdoid, the squamous, the coronal, etc. You can see on here the sagittal suture, okay? The lambdoid back here, etc. All right? Then if you go over to here, you have these lesser movements between the proximal radial ulnar joint and basically the distal radial ulnar joint. This is a clear example of a gomphosis. All right? These are the things you want to note. There's a little bit of movement on these joints and these joints, and for example, also in the leg joints, but you really can't have anything of any movement here. Cartilaginous joints are two types, the symphyses and the synchondroses. Now, the symphyses, the two areas you're going to see this is the pubic syphus. Okay, that's the bone between the two coxae sets of bones, okay, at the pubic syphus. Also, the intervertebral discs, all right? The synchondroses, this is the epiphyseal plate that you see that is temporary but exists between the epiphyseal part of the bone and the diaphyses. Also, you have something that's more permanent, and that's the first rib and the manubrium. So, here's the first rib over here, and you have the manubrium up here, okay? Now, vertebral ligaments, you can see here you have these longitudinal ligaments up here. You have the ligament flava here, and you have, of course, the posterior longitudinal ligament right here, as well as the interspinous ligament and the supraspinous ligament. What these are all doing is allow for a little bit of movement, but not tremendous, okay? And what's held between them also are these intervertebral discs consisting of the tough outer material, the annulus fibrous, and then, of course, this kind of tough, but at the same time somewhat fluid-like nucleus pulposus here. Okay. Now we get into synovial joints. This is defined as having a fluid-filled cavity between the articulating surfaces. You're going to have gliding movements, flexion, extension, and hyperextension. You need to get these terms down and understand them very, very well. Gliding movements, you have the articulating surfaces of two bones. They move back and forth, or side to side, or diagonally, such as in linear motion. Flexion, this is the movement that decreases the angle between the articulating bones. So one way to do it is you've curved your bones, you've brought your elbow up to a 90-degree angle, and now you're just going to extend the bone. That's flexion. Extension is the opposite. So the movement increases the angle between. Okay? Now when I say increase, decrease, hold on. Flexion is when, you say flex those muscles. Okay, fine. Movement that decreases the angle between the articulating bones. So I stand corrected. I take my arm, it's outstretched, and then what happens is I start curling my arm. The forearm rises. The angle between, let's say, my upper arm and my lower arm goes 135, 120, 90 degrees, 60 degrees, 45 degrees, and that's about it. Extension is the opposite. So you're increasing the angle between the articulating bones. So if the articulating bones are the forearm versus the humerus, as you increase or stretch outward, that's extension. So you extend your arm or you flex your arm, if those terms help you. Hyperextension, though, is extension past the anatomical position. That can happen with some people, and they can have great pain, or bones can be coming out of joint in these situations. Then we have these other joint movements, which we would talk about for a minute. Angular movements, the motion in which the bones cause them to either increase or decrease angles between the bones. So you have abduction and adduction. Abduction is movement away from the longitudinal plane of the body in the frontal plane, longitudinal axis. So what am I saying? It's as if you have your arms side by side and you start moving them outward, okay? Adduction is movement toward the longitudinal axis of the body in the frontal plane. Circumduction is a little bit different. It's a conical movement of the body part, such as with a ball and socket joint or the eye. So you're rotating your arm. Rotate it with the wrist being able to be freely in a conical shape, and all of the movement really is at the shoulder joint. The movement of a body region in a circular manner, in which one end of the body region being moved stays relatively stationary, while the other basically describes a circle. So let's go through this using this character here. If you take the head at the joint, you can have flexion, so the angle between the head and the body. Flexion, the angle decreases. Extension would be doing the opposite. Hyperextension would be increasing it beyond that point of the extension. So instead of straight, you're moving the head backwards. Here we have also flexion and extension. The person is trying to make a muscle. That's flexing the arm, and then extending it is straightening it out. And you can see the situation here with flexion extension, and hyperextension. Now, looking at this model here, what you're going to do is abduction. So you're going to basically have it at your side, and you're going to increase the angle here. And adduction is bring it back to the longitudinal axis here. This is circumduction. It's almost as if you're trying to use at the center. That's what the red dots are for. That would be where the site of the joint is. The arm is extended, and you're making somewhat of a large circular or sweeping motion. Now, that we've gone through a lot of the basics of movements, we've got to go through some of the specialized ones that are present in select joints in the body. Right and left rotation. This is turning the body left or right around the midline of the body. Medial, internal rotation movement. That's where the anterior surface of moving part is brought towards the medial plane. Lateral, that is external rotation movement, is the anterior surface of the moving part is brought away from the medial plane. Now we get into pronation, supination. This is really where you're going to see this with the radius and the ulna. Rotation of the radius around the ulna at the proximal and distal radial ulnar joint. It allows you to do this. Opposition. The thumb is brought over to touch another digit. Eversion, inversion. This is where you take the sole of the foot, and the joint really is at the ankle, and you move it away or towards the median plane, so sort of the midline. Dorsiflexion, plantar flexion. This is a bending action that elevates the soles of the foot, or bending action that elevates the heel. Rotational special movements, just two more. Protraction, retraction. This is an interesting one because it's involving the mandible, which moves anteriorly or posteriorly. Protraction, you bring the jaw out in front of the face almost. Retraction, you bring it back to its natural position. Depression, elevation. This is where you get to move the lower jaw, and it will move inferiorly, almost as if you're surprised. Oh! And then elevation. You bring the mandible up against the maxilla. So you close it, move superiorly. You can see these motions here, and yes, you are responsible to know these joints. The allentoaxial joint, this is between C1 and C2. The lateral rotation, the internal rotation, or medial rotation. You'll note all of this is occurring because of the movement of the joints that are in the radius and the ulna. Dorsiflexion, plantar flexion. Okay, so here we have dorsa. We're bringing up. This is always occurring via the ankle, and so you bring the front part of the foot upwards. Bringing it downwards, that's ankle extension. Inversion, eversion. Inversion, this is all occurring around the ankle, and so you move the sole of the foot inward toward the midline, and that's inversion. Moving it away, that's eversion. Then we have opposition. You're basically using your finger, your thumb, to come in contact with the other fingers. Here we have depression. What? And then elevation, closing the mouth. Retraction, protraction. Protraction, you bring the jaw forward. Retraction, you bring it back. This is all at the TMJ joint too. Gliding and hinge joints. These have small, flat articulating surfaces. For example, the intercarpal joints. Hinge joints have one articulating surface that is convex while the other one is concave. An example of this is the elbow joint, and I expect you to review and complete the tables 138, 139. As you can see here we have some of these joints that you're going to start seeing. You're going to also see hinge joints, okay? And so you see how these joints move in different directions compared to the other bone. And having all of these, the hinge joint here is up and down. Now again, this is because part of these components of the bone of the ulna stabilize the movement here. Pivot and ellipsoid joints. Pivot joints have a rounded surface on one bone that fits into a shallow depression of another bone. The radioulnar joints and the allantoaxial joint are examples. Condylar joints, you have an oval-shaped convex surface which articulates with a shallow elliptical cavity. This is called a biaxial joint. An example of that would be, of course, the wrist joints. And I encourage you to complete and review tables on 140, 141. So here is an example of a pivot joint. It's going to go side to side, no problem. A condylar joint, you have here is the scaphoid bone, and it's going to move in different sides against the radius. The saddle and ball, as well as the socket joints. The saddle joint and the ball and socket joints. Saddle joints are basically the articulating surface has a convex and a concave region. So one bows outward, one bows inward. And so you form what is called a biaxial joint. An example of that is the carpometacarpal joint of the thumb. The ball and socket joins a rounded head which articulates with a cup-like concavity. This is what we refer to as a triaxial joint. Now, axial this and axial that, what are we talking about? If I say biaxial, it's moving in two axes. So it might be able to go in the x-axis back and forth, but it at the same time might be able to do something else in the sense of moving, let's say, side to side. That would be in the z-axis, or up and down, that would be in the y-axis. But biaxial, there's only two axes of movement. Triaxial, that's where it gets really interesting because you now have three axes. So back and forth, up and down, side to side. And I encourage you to take some time. You can look at this from the shoulder joint, but complete the tables on 142 and 143. So you see the saddle joint here. Here is the nesting pockets for both. As you can see, you have them riding on top of each other. The ball and joint model is really dependent on having this shoulder free to be able to rotate and go from side to side and up and down. Now, let's go over some other synovial joints in the upper limb for a minute. Shoulder joint has the greatest range of motion of any joint in the body. A side of articular cartilage, a fluid-filled joint, accessory structures of ligaments, bursa, menisci, and fat pads, they all add stability to the joint. So the components that make this up are the glenoid labrum, the acromioclavicular ligament, the coracoclavicular ligaments, there's two of them, the coracoacromial ligament, the coracohumeral ligament, and the glenohumeral ligament. Now, hence the legitimate names. This is where people get really confused, and so I'm going to give you a couple of little helpful points. When I say coraco, this is an attachment to the coracoid process. Acromonial, attachment to the acrimon. numerical, humerical. This is attachment to the humerus, and clavicular is an attachment to the clavicle. As you can see here, here are our coracoacromial ligament from basically this this section of the acromonon, and the coraco ligament, okay? The coracoprocess, I should say. You have over here, basically the clavicle. You have articular capsule. You have the synovial membrane here and here. So basically in this space here is filled with some fluid to provide movement and stability. The scapula, the articular cartilages here and here, okay? The ligaments stabilizing the shoulder, we've talked about the coracoclavicular ligament, the acromonian clavicular ligament, the coracoid acromonial ligament, the coracoid humeral ligament, and the glenohumeral ligament. You need to know all of these, okay? Note that there's also the presence of some bursa, okay? Now, when we talk about the next set of synovial joints of the upper limb, we have the elbow joint. This is the shapes of the articulating surfaces, and the collateral ligaments allow for flexion and extension, but really they prevent other movements, so you don't have it going sideways. You see an arm and it's set sideways, there's a problem, and the problem is also going to be the patient in a lot of pain. The ligaments that play a role in this elbow joint include the annual ligament, medial and lateral. The medial is ulnar collateral ligament. The lateral part would be the radiocollateral ligament. And you can review the tables on 144 and 145, fill them out. Here you can see why this particular elbow is really a uni-axle, as they refer to it, because it can go up and down, but it can't go anywhere else. So radiocollateral ligament is here, an annual ligament is here, the capitulum of the humerus is right here, the radial tuberosity is here, and then we have the antebrachial interosseous membrane here, as well as here. So we've had this as sort of the lateral view. Let's take a look at this on the medial view. Obviously, there are some annual ligaments that are present. Then what we have is the tendon of the biceps brachii. The annular ligament is wrapped around the radius. This is going to add further stability. You have the articular capsule, you have the medial epicondyle, and the ulnar collected ligament here and here. Okay? This is the olecranon. The anterior view. Here we have what you would see is, again, the elbow joint, radius ulna humerus. Okay? Proximal radial ulnar joint right there. Humeral radial joint right here. Humeral ulnar joint right there. Okay? Notice that you've got this ulna fitting into the olecranal fossa, as I said. So it sort of fits in there nicely. Synovial joints of the lower limb. The biggie is the hip joint and the knee joint. So we're going to do hip joint first. This is going to provide you with stability, durability, in allowing you to support and transmit all of the weight of the upper body. The stability is achieved by these three ligaments: iliofemoral, pubofemoral, ischiofemoral ligament. The acetabular labrum, this is a fibrocartilage pad in the acetabulum. Of course, you got the acetabular notch. You have the transverse acetabular ligament, which crosses the acetabular notch, fills in the gap in the inferior border of the acetabulum. The ligament of the femoral head, which is called the ligament teres, that attaches to the ligament of the femoral head. So you see this ligament teres, this is going to attach here, and it's going to attach to the ball on the humerus, on the femur, okay? Now, notice you're going to have an iliofemoral ligament. Lots and lots of articular cartilage here. The acetabulum, the ligament teres, the transverse acetabular ligament right here, and the acetabulum, all of it. That's without the femur. Put the femur in, and now what you have to do is start seeing the reinforcing ligaments: pubofemoral, iliofemoral, ischiofemoral, coming off from the femur. The technique of the ischial tuberosity right here, the greater trochanter and the lesser trochanter, and the intertrochanter line. Why am I doing this, you might say? Is it a lot of minutia? No, it's not. Because we have so many people, because of sports or war injuries, or just because of aging, they're coming in contact with wear and tear that really becomes difficult as they get on to their later lives. So it's important to know these joints and to know where and how they function. The knee joint is a modified hinge joint, and it provides flexion and extension of the leg, along with a slight medial and lateral rotation. Stability provided by the ligaments and the menisci. This is the fibrocartilage C-shaped plates on the tibia. What you got are the quadriceps tendon, the patella ligament, the fibular collateral ligament, the tibio-collateral ligament, and the popliteal ligament. Then you have an anterior and posterior cruciate ligament. This is the one that forms kind of like an X on the inside. It's found within the joint capsule and crosses each other. Then you have the lateral and medial meniscus. Those are thickened pads to handle the weight. You are expected to complete the questions on pages 146 and 147. Now look, here's what's going on. This is with all sorts of the ligaments present as well as the knee joint. You can see here are the larger quadricep muscles here, the quadricep tendon, the joint capsules underneath here, the fibular lateral collateral ligament, which is LCL, the fibula, we've got the tibia, and the patellar, which is the ligament here. So you got quadriceps tendon and a patellar ligament that hold and stabilize the patella where it is. All right. Notice that down underneath here, and you can just barely see it, is the bursa. The fibular collateral ligament, that's on the side here. So in other words, what I'm saying to you is you need some side ligaments to keep this from not buckling. You have the tibial medial collateral ligament, the MCL right here. Fibular, if you want to say that, the FCL, it's here. The tendon for the biceps femoris muscle, that's been trimmed away, so you can see all of this, but it's still important. The popliteal ligaments are here and here. Now, if you start stripping away all the ligaments and such, you're going to see underneath. In the deep anterior view, flexed, you will see the presence of the fibular collateral ligament, the tibial collateral ligament, but what's even more important are the lateral and medial condyles, the lateral and medial menisci, and then really the posterior cruciate ligament and the anterior cruciate ligament. And when I say cruciate, they kind of form an X. Okay? That's what you need to keep in mind. Now here I've stripped away more of this and gotten a different view. So I have the ACL here, okay? I've got the medial and lateral menisci here and here. The tibial collateral ligament is right here. The fibular is right back there. The tibia and the fibula are here. And you can see where the ACL and the PCL is. So that pretty much ends this. Wow, that was a lot. Here's what I want you to do. Download those exercise sheets, okay? Now, pages 125, so it'd be 126, 127, 128. Got to fill it out. It's all set up as a form, so no problem. Remember to save it as a PDF. Review exercise 9.1 to 9.9 and complete the pages 149 and 152. So that's 149, 150, 151, and 52. Okay, great. You don't hand it in to me. You upload this. It has to be present on the website. You upload it onto the Blackboard, the same site that you got it from downloading it. Upload it as a PDF, go over it, and you'll get graded. We do not have bone models in front of us. We do have videos of people going over those bone models. Any images in Syracuse is fair game for the lab practical exam. Take time to review the other lab videos and go over the lab manual notes. This lab concludes all lab content for lab manual exercises 1 through 9. So lab exam 1 is occurring later on in the week. Make sure that you take time to review all of this content, and we'll see you later. Have a wonderful day.